Mitral stenosis. Etiology. Most mitral stenosis, MS, is acquired through rheumatic heart disease. It is more common in women, presenting in developed countries in the 4th or 5th decades of life. Clinical presentation. MS commonly presents with the following: exertional dyspnoea, orthopnoea, paroxysmal nocturnal dyspnoea, hemoptysis, palpitations, fatigue, weight loss, embolic phenomena in up to 15%. Physical signs. General features. Comment on the patient's general well-being and in particular if she is short of breath at rest or cyanosed. Look for surgical scars, particularly a mitral valvotomy under the left breast. Does the patient have a malar flush? Cardiovascular examination. Check for stigmata of endocarditis. Pay attention to dental hygiene. In mitral stenosis, MS, the following may be seen. Pulse, atrial fibrillation, AF, is very common in MS. Signs of heart failure, elevated JVP and giant V waves due to secondary tricuspid incompetence, also hepatomegaly, ascites and ankle edema. Apex beat, tapping, palpable first heart sound, that is not displaced. Parasternal heave, suggests pulmonary hypertension. Heart sounds, the first is loud, then there is a loud pulmonary second sound and an opening snap followed by a mid-diastolic rumbling murmur, with presystolic accentuation if the patient is in sinus rhythm, localized to the apex and heard loudest in expiration with the patient in the left lateral position. A Graham-Steele early diastolic murmur due to secondary pulmonary regurgitation may be heard. Investigations. ECG. Normal. Left atrial enlargement or atrial fibrillation, AF. Right ventricular hypertrophy. Chest radiograph. Normal. Straightening of left cardiac border as a result of dilated left atrial appendage. Pulmonary edema. Atrial double shadow along right cardiac border, Fig. 55. Echocardiography. This enables visualization of leaflet mobility and calcification. Quantification of the valve area and mean gradient, Table 28, are derived from continuous wave Doppler. Left atrial size and right ventricular function should be assessed. Left ventricular size is usually small and left ventricular systolic function normal. Doppler echocardiography allows estimation of the pulmonary artery pressure, PAP. A transoesophageal study is usually required to assess suitability for valvuloplasty if this is being considered, Fig. 56. Cardiac catheterization. This is advisable when patient symptoms and echocardiographic findings are discordant or coexistent coronary artery disease is suspected. The mean mitral valve, MV, Gradient can be calculated from the difference between left ventricular end diastolic pressure and pulmonary artery wedge pressure recorded simultaneously. Dynamic assessment. Some symptomatic patients may have evidence of only mild or moderate MS at rest. However, during exercise the rate of mitral inflow increases, which may cause the transvalvular gradient to increase significantly. Diastolic filling time may also be reduced, causing raised left atrial pressure. Exercise echocardiography should therefore be considered in patients who are symptomatic with apparent mild or moderate disease only, and no other explanation for their symptoms, e.g. anemia, other valvular disease or coronary artery disease. An increase in mean MV gradient to more than 15 mmHg or PAP to more than 60 mmHg with exercise is considered significant. Differential diagnosis. Consider the following. Austin Flint murmur, of aortic regurgitation. Left atrial myxoma. Tricuspid stenosis. Treatment. Emergency. Treat acute pulmonary edema with diuretics. Short term. Beta blockers or rate-limiting calcium antagonists may help symptoms. AF may require treatment. Long-term. Formal anticoagulation with warfarin is required. Antibiotic prophylaxis is needed irrespective of severity. Intervention is required if there is severe stenosis and symptoms. If the MV has minimal calcification, there is merely mild mitral regurgitation and there is no evidence of left atrial thrombus, then mitral valvuloplasty should be considered. Otherwise, open valvuloplasty or MV replacement is required. Complications. The following are possible. AF. Pulmonary hypertension or infarction. Chest infections. Tricuspid regurgitation. Right ventricular failure. Thromboembolic disease. Prognosis. In severe MS, 5-year survival rates range from 62% with New York Heart Association Class 3 symptoms to 15% with Class 4. After surgery, 5-year survival rates are between 90 and 96%.